done lots of studies over the years, and I've come to a lot of meetings. And when I left the house, I asked my wife, I said, well, honey, how do you explain our being married for almost 33 years? She said, lack of imagination. So I hope it's not that. I hope that that's not the reason that you keep inviting me. But in a former life, I don't have my slides, but I could summarize this even if they don't come up. But former life, I did a lot of physiology on why syrinxes develop in Chiari 1 patients. And then I guess as you get older, you get more philosophical, and you realize that what's most important to the patients is how they do and their symptoms. And frankly, I was, it was interesting doing the physiology, but as things went on, it seemed like the patients really were most interested in being treated and getting the best outcome. And they had significant problems. So what we're interested in is looking at pain and functional abilities in our Chiari 1 patients. Now, I just want to talk a little bit, just some broad concepts of research and what we think about when we're starting a research project. We want to improve the understanding or care of a significant health problem. And in this case, it's Chiari 1 malformation. So we want to frame questions that if we answer them, we can improve the understanding or treatment of the conditions. For example, do syrinx shunts improve the outcome of craniocervical decompression for Chiari 1 malformation? There were numerous retrospective clinical studies, and they came to the same conclusion. So when you have great agreement, that answers a question. And as you can see from this group of studies, and Dr. Batzdorf's in the audience here, he contributed to this as well as Bernard Williams. And in these studies, it showed that really decompression had a better end result than decompression plus shunts. And that was pretty much, for neurosurgeons, the ends of routine shunts. And before these studies were performed, patients would get Chiari decompression plus a shunt, but no longer. So that the question was answered and it changed behavior. Okay, so Dr. Frim's going to talk about this later. What's the expected outcome of Chiari 1 surgery? That was his question, and he developed this scale to make it easier. It was a tool, it's technology. Usually advances come from improved technology. And so he came up with this scale, and he'll talk about that later. So Dr. Iskandar is going to talk about what type of craniocervical decompression operation is most effective in decreasing the size of a syrinx in patients with Chiari 1 malformation and Chiari 1 related syringomyelia. He'll talk about that. That's an outcome study, but that all arises. You have to pose a question and then try to answer it. So what's the question for my study? Well, we have lots of questions. In a typical patient with syringomyelia and or Chiari 1 malformation, what is the pain level? What's the functional ability? How do pain and function change over time? And what's the effect of surgery on pain and function in patients with progressively worsening symptoms? So this study is different from some of the other studies you'll hear about because all patients receive the same tests before and after surgery. It's not from like the Chicago Outcome Scale study because it's prospective. Our patients are tested before surgery, so we'll have an outcome after surgery that can be compared to a test before surgery. And not all patients in our study undergo surgery. And it's different from the ASAP Chiari study because, again, not all patients undergo surgery. Some are observed, and our patients receive one standard therapy. They don't have this versus that. And it's a natural history study. So the patients who aren't operated, we see how the disease changes over time. So these are preliminary results. The study's going on for 5 years, and we've enrolled our 120 subjects so far, but we haven't analyzed that many. I'm only going to report on the first 56 patients, and I'm going to select out two things, pain and function on the Karnofsky performance status. And all these when these, and Mrs. London knows this, but when I'm out of the room when the patients fill out these forms, and most of the time the patients are in with the residents who probably encourage them to rate them lower instead of better after surgery. But anyways, so we have a surgical group, and they have to have advancing neurologic deficit, or what I consider debilitating morbidity, leading to reduced quality of life. And then we have a non-surgical group, and we consider those people to have stable symptoms. And so far we have an equal mix, 28 with surgery, 28 with observation, and we have patients that I'm going to report here who have Chiari with syrinx, Chiari, or without syrinx, Chiari with syrinx, and syrinx without Chiari 1. So we perform these functional tests, but I'm going to focus on this one today, the Karnofsky scale. For our pain assessment, we have this form the patients fill out. What's your headache been? What's your global pain? In other words, what's the average, the worst pain you've had, the average pain, the least pain, and we check the medications the patients are on. And then we use the McGill pain questionnaire, where they rate their types of pain and how intense it is, 10 being the worst possible, 0 being no pain. And here's the Karnofsky scale. This is taken from cancer. 100 would be normal, 0 would be dead. Below, yeah. Well, some people die. You know, you have to have that score. Not in our study, but that's a possibility. That's frankly, that is a possibility. Surgery is a serious matter, and you can die from other conditions too. So, anyways, basically, this is the cutoff point, 60. After 60, you're really considered to be really dependent, and then between 60 and 70, you can do most of the things for yourself, but you need help. And 80 to 100, you have or 80 and 90, you have some problems, but you're pretty much getting by with effort. All right, so these are self-reported scales. It wasn't my guess at how patients were doing. The Chiari patients without syringomyelia, they all said when they rated their scores that they had severe pain, 7 to 10, 10 being the worst possible. So they reported a lot of pain. Chiari 1 with syrinx, they had, for the most part, some had mild pain, some had moderate, some had severe pain. For primary syringomyelia, very few people have no pain. And none of the patients with Chiari 1 with syringomyelia or Chiari 1 without syringomyelia reported no pain. But a few of the primary spinal patients had no pain. So really, when we looked at it, there wasn't, here are the surgery patients in black, here are the non-surgery patients. There wasn't any difference in the pain level of the patients who we thought were progressing and the people who we thought were stable. And the patients with primary spinal syringomyelia, the ones who chose to have surgery generally had more pain. You can see here a great degree of pain. Fewer patients than the non-surgery group had a high degree of pain. Okay, so now we're going to, that was pain. Now we're going to compare function between the patients at the initial visit in the surgical and non-surgical group. So have a minor deficit that was seen in a few patients that had surgery, but most of the patients who had surgery had more functional impairment. And most of the patients who didn't have surgery had high function. With Chiari 1 with syrinx, you can see that patients had intermediate levels of disability, and a few patients that had surgery had high degrees of disability. And with primary syringomyelia, the patients who didn't have surgery had the best function, had much better function. So patients who underwent surgery had a lower KPS score. And so as a neurosurgeon, I look more at function than pain. Pain, so we look at neurologic dysfunction. We look at how people are performing when we make our decision to have surgery. Now, other people might have different criteria. Okay, so 1 year after surgery, we looked at the pain. So for Chiari without syrinx, these are just the surgical patients. Here's baseline, here's follow-up. They had severe pain before surgery, they had severe pain afterwards. That's when they rated it themselves. Now, if I rated it, they'd be much better, I can tell you that. Okay, Chiari with syrinx, again, very similar. How the patients rated their pain, very similar before and after surgery. And in the primary spinal syringomyelia group at follow-up, they had less pain in general. Some of the people with severe pain went to the moderate pain group. Now, pain is a little bit tricky because what we do is we write down as a pain score the worst pain. So for example, on this patient, this is before decompression, many 10s, everything's over here. There's a little shift to less pain on this patient, but still had a 10. So really on the scale, you would say there was no improvement in pain, even though some aspects of the pain improved. As a neurosurgeon, this is what we're looking for. You know, before surgery, here's a Chiari malformation, there's syringomyelia, we like to decompress, the syrinx goes away. We pat ourselves on the back, and we pat the patients on the back, and we tell them it was nice being their doctor, and we'll see them again at a meeting or something, you know. But for the patients, it's not like that. And we looked at, you know, we're patting ourselves on the back, and we looked at syrinx diameter, and it went down. You know, some of the syrinxes, you know, some of them disappeared completely. But really, if there was a correlation, people would have more pain when the syrinx got smaller, not less pain, which was really not what we were looking for when we designed the study. Okay, so let's go to the patients in the non-surgical group. Before surgery, severe pain. After, well, I mean, before they were observed, severe pain. After they were observed, still had severe pain. And the Chiari with syrinxes, for them to be stable, their syrinxes generally were smaller. There actually was some movement. Some of the patients went from mild pain to no pain. And so that's a good thing, really. And okay, so the patients who underwent surgery with and without syrinx, we did see an improvement in function, which was good. In other words, if you had an ADL, the lower score is worse. If you had an ADL of 70 to 80, that means that you needed considerable help to get by, but still had some independence. At follow-up, there were fewer people in that group, and more people had very minor impairment in function. Chiari with syrinx, the people who had severe disability, they moved. So there was a move toward less disability with surgery, as you'd expect. With the primary spinal, they, at follow-up, we reduced some, in a few people, their severe disability, but really, other than that, there wasn't much change. Okay, in the non-surgical group, with the patients with syrinx, you see some improvement where they move to minor disability. With Chiari with syrinx, more people with minor disabilities, so you're moving this way toward better function. And Chiari without syrinx, it's about the same. We also, and I haven't analyzed these numbers, but we've also looked at function on other scales, such as functional independence measures. And this is fairly typical. People report these types of problems, in this case, grooming, dressing upper body, partly independent, expression, they have some cognitive problems. But look at in the cognitive section how this person with Chiari, moderate assistance, maximal assistance, and they improved after surgery, but they didn't improve to normal. Okay, so in summary, the surgery didn't seem to improve pain, but the functional outcome did improve in the surgical group, and we did surgery on the patients who had progressive symptoms. In the non-surgical group, patients were improved or unchanged. And I think that's because patients had scans and they had been observed for a year and they knew that their disease was stable and they were less anxietous about it and they could move on better. So knowledge, I believe, improved their lives. And we found that the pain didn't change with a reduction in syrinx size after surgery. The surgical treatment halted neurologic progression, and we thought our criteria for selecting patients who did or did not need surgery were appropriate. In other words, the people we chose to not do surgery on didn't progress. So if we included them in a surgical series, for the surgery to have been beneficial to that group, that group of patients would have had to do as well as a non-operated patient. So as a practitioner, not as a surgeon, but as a practitioner, patients did better not having surgery in that group, and that was the right decision. Okay, and then in the rating scales, they're all interdependent, but cognitive function was associated with Karnofsky score. So, we're thinking about neurologic deficit being very important in patients with Chiari, and we're thinking of motor deficit, ataxia, and so forth. But for whatever reason, cognitive function, thinking, being able to function well, thinking and impairments of thinking, that affected the performance significantly. And Dr. Kula, I hope he agrees with this. He's been seeing patients for many years. I know the parts he doesn't agree with. Okay, but okay. So all patients with Syringomyelia or Chiari malformation type 1 had significant or some amount of pain, and most had reduced quality of life. And the pain, the weakness, the sensory loss, it persisted over time, and it didn't respond completely to surgical treatment. And that's because if you have a syrinx, it can cause irreversible damage to the spinal cord. And once you have a disability, it really is difficult to reverse it. The pain is difficult to reverse. You can reverse some disability. Okay, so I'm preaching to the choir here, but commonest problems causing disability in Chiari 1 patients before and after surgery: headaches, pain primarily in the neck and shoulder girdles, imbalance, and cognitive complaints. And we need better non-surgical treatments to relieve the pain that persists after surgery. And not all patients with Chiari 1 and or Syringomyelia need surgery, because the stable ones don't need surgery. And some people have been stable for many years. So this is where I work, and I have colleagues that help me with the work. So thank you very much.